Thank you everyone for coming tonight. This is our clinical case webinar on drugs, alcohol, and the liver. And this will be presented by Dr. Emily Nash, who is a gastroenterologist, hepatologist, and addiction medicine specialist. She has public appointments at Royal Prince Alfred Hospital in both the Gastroenterology and Liver Center and Drug Health Services. And she also has a clinical and research interest in alcohol-associated liver disease and runs an integrated addiction clinic, which is co-located within the liver clinic at RPA. So with all of these qualifications, I think it will be a very interesting talk with all her experience and expertise. This is the last clinical case webinar that we have for the year, so tune in for next year's updates. I'd like to begin by acknowledging the traditional custodians of the country and lands in which we meet and recognize continuing connection to land, water, and culture. And just very quickly, these are the registrations for tonight. As usual, we do have a lot of metropolitan, but we also do have a lot of people from the ACT and around in the regional LHDs. And then these are also the breakdowns of the specialties for tonight. A lot of GPs, which will be very interesting, as well as addiction medicine and psychiatry. And we also have a lot of nurse practitioners and almost every role represented. So thank you very much for coming tonight. Just a little bit about the webinars, since this one is the last one. We typically have them every month, and after the webinar, we will send a certificate of participation that you can use to claim CPD points. And the webinar is recorded and will be made available on the OTAC website along with a PDF of the slides. Just some general housekeeping. Please keep yourselves on mute. If you would like to ask a question, please put it in the chat, and after each subsection, Dr. Sharon Reed will read out the questions. And yes, please be considerate and polite, and just note that the webinars are recorded. So now I will turn it over to Dr. Emily Nash. Thank you very much.
So welcome everyone, and I'm delighted to see such a diverse wealth of experience in the audience tonight, and I look forward to some of the discussions later on. So for me, the liver is where my two specialty areas intersect. So people with substance use disorders are more likely to develop a range of liver diseases, and that will be the focus of our talk tonight. It's also important to remember that the presence of liver disease can impact how you manage people with substance use disorders, but that's a talk for another time. All right, so what I'm hoping by the end of this hour you'll be able to do is to be familiar with liver diseases which occur most commonly in people who use alcohol or other drugs, to be able to interpret Hep B serology and know when to refer for treatment, to be able to treat hepatitis C, because we can all do this now, to be able to assess the degree of fibrosis in chronic liver diseases, and to be able to screen for hepatocellular carcinoma in patients with cirrhosis. Now, this is a very busy slide, but I simply want to make 3 points about the diseases that we're discussing tonight. So this is liver transplants in Australian adults from the beginning of liver transplant time in the 80s up until a couple of years ago. The black bars at the bottom show that transplants for alcohol-related cirrhosis are increasing. The brown bars at the top show that transplants for hepatitis B are pretty steady. And the purple bars show that transplants for Hep C are coming down, and this is due to the highly efficacious direct-acting antivirals, which became widely available in about 2016. So the first case we're going to talk about is a case of hepatitis B, and I have a multiple choice question which you'll all be able to answer through Zoom. So Van is a 32-year-old man currently on long-acting injectable buprenorphine for opioid dependence. You perform a bloodborne virus screen, which shows Hep B surface antigen negative, Hep B surface antibody positive, and core antibody positive. Which best describes Van's hepatitis B status? Okay, yep, so 58% of people got that one correct. So Van is Hep B immune from exposure. So if your surface antigen is positive, that means you have chronic hepatitis B. If your surface antibody is positive, then you've been exposed to the virus either through vaccination or through actually being exposed to the virus. And if your core antibody is positive, then that means you've been exposed to the actual virus, because that is not a result of vaccination. So it turns out that Van was born in Vietnam. His sister, who has never injected drugs, has chronic hepatitis B. So most likely they've acquired it from their mother, either during pregnancy or delivery. And acquiring Hep B as a baby or a child means that there's a 90% chance of that infection becoming a chronic infection and persisting into adulthood. Whereas if you acquire hepatitis B as an adult, because your immune system is much more developed, there's actually a 90% chance that you will clear it and it won't become a chronic infection. However, the tricky thing about Hep B is that the covalently closed circular DNA, which is a template for viral replication, will forever live in your hepatocytes and can be reactivated, typically with high dose immunosuppression, and we'll get to that. So it is rare to have acquired Hep B as an infant and to not have a chronic infection. So in New South Wales, 70% of people living with Hep B were born overseas in a high prevalence country. Hep B is transmitted via contact with bodily fluids, so not just blood, but it can be through semen, vaginal secretions, or saliva from an infected, so a surface antigen positive person, and it gets in via broken skin, the bloodstream, placenta, or mucosal membranes. It has a very high concentration in blood, so you only need quite a small inoculum to cause an infection. And with chronic Hep B, the thing that we worry about is the development of liver disease, which can result in cirrhosis, which can lead to complications, including hepatocellular carcinoma. And in fact, in Hep B, you can get a HCC even if you're not cirrhotic, which is not typically seen in most other liver diseases. In Hep C, it's just genotype 1A that can happen, but typically you need cirrhosis in other liver diseases. So the typical incubation is about 6 weeks to 6 months. And if we're doing regular bloodborne virus screening in high risk people with ongoing exposures, then hopefully it can be detected. So it is a preventable disease, and in Australia, universal vaccination from birth was implemented in around the year 2000. There's also a program for adults to be vaccinated, which is a 3-dose schedule. Pregnant women are screened, and if they have a high viral load, they're offered antivirals in 3rd trimester to reduce transmission to the infant. And if a baby is born of a surface antigen positive mother, then Hep B immunoglobulin is given at birth, which is a type of post-exposure prophylaxis. Other ways that Hep B can be prevented are sterile injecting equipment, needle syringe programs, and condoms. Now, in terms of the vaccination, sometimes there may be, so typically the minimum duration, the 3 doses can be given over to adults is 4 months, but typically it's 6 months, so 0, 1, and 6. If there is a longer gap in between doses, it does not affect the immunogenicity of the vaccine. It just means that they're potentially being unprotected for longer. So with 1 dose of vaccine, typically gets seroconversion in around 30 to 50% of people. A 2nd dose increases that to about 75%. And with the 3rd dose, that rate is even higher, and it also provides a more durable, longer-term protection from hepatitis B. So if you have someone who's had even just 1 dose of the vaccine and they've sort of dropped off and haven't had the remaining doses, just give them as soon as you see them again and is practically possible to do. In terms of confirming whether they have seroconverted, that's not routinely done except in high-risk people, like people on dialysis or who are immunosuppressed. So in those cases, you would check a surface antibody 4 to 8 weeks after completion of the course. And if their surface antibody is greater than 10, then that confers protection. If it's less than 10, then you can give them a 4th dose to see if they're a non-responder. And then checking the antibody level again 4 to 8 weeks after that. If the surface antibody remains less than 10, then you proceed to give them another course. And if that does not result in seroconversion, then there's not really much you can do in terms of prevention, but you need to inform the patient and let them know that if they ever do have an exposure to someone who's confirmed to have chronic Hep B, that they would be offered Hep B immunoglobulin. Oh, sorry, didn't mean to do that. All right, now Hep B serology is, there's a lot of tests to be interpreted to determine someone's status. And if you're not doing a lot of this, then this is sort of the things that you've learnt in med school that you sort of will revisit every 6 months to refresh. But it sounds like most of you are doing regular Hep B work based on the answers to the question. So the surface antibody means you're immune either after an infection or vaccination, and the titer greater than 10 correlates with protection. Core antibody, so core IgG is typically what's tested if you ask for a core antibody. That indicates a past exposure to Hep B. So interpreting that with, if there's a surface antibody, then they have recovered from the infection and are immune. But if there's a surface antigen, that means a chronic Hep B infection. To diagnose acute Hep B, we check an IgM with a titer, and if it's a very high titer, that indicates an acute infection, which distinguishes it from a chronic one. The E antigen isn't really part of the diagnosis, but you can test for it, and it can be important in terms of commencing antivirals. So it's typically positive in an acute Hep B infection, and it's a marker of infectivity. In chronic Hep B, it usually correlates with the DNA level, which the DNA suggests or indicates active viral replication and infectivity. Having said all of that, you can have surface antigen negative Hep B, which is due to a mutant form, where you will typically have a high ALT and not be able to explain it, and check a DNA, and that could be, if it's elevated, that's probably a mutant form. The E antibody suggests convalescence after an acute infection. It's typically correlated with lower viral loads. So you might be wondering where the core antigen is. We don't test for that in the serum, and we can't because it's located in the hepatocytes in the liver tissue. All right, so now onto the simplified table, which is the 3 tests you would do if you're trying to diagnose Hep B. So if the surface antigen, surface antibody, and core antibody are all negative, that person is susceptible and they should be offered vaccination. If just their surface antibody is positive, then they've most likely been vaccinated and there's nothing further to do if the titer is greater than 10. If the core and surface antibodies are positive but they don't have a surface antigen, then that's a past infection, and they're, for all intents and purposes, immune. Unless they go on certain immunosuppression, they need prophylaxis. Family members and sexual contacts or people they may have shared a needle with should be tested. An acute infection is suggested by a surface antigen and a core IgM positive, and again, they should have contact testing and tracing, and refer them to a hepatologist, or if you're an S100 prescriber and prescribing antivirals, then you may be able to manage them yourself. And a chronic infection is where there's, so basically if the surface antigen persists for more than 6 months, then it's a chronic infection, and they would have a core antibody IgG positive. In terms of an acute infection, this is detected in less than 50% of people because most cases are asymptomatic. If they do get symptoms, they'll typically develop a serum sickness type illness with fevers and myalgia. They can then develop a hepatitis with some right upper quadrant discomfort, nausea and vomiting. They can get some arthralgia and possibly a rash. In children, less than 10% have symptoms, and infants are usually completely asymptomatic. So this is what should happen when you are exposed to the hepatitis B virus. So the surface antigen is positive, and then it goes down as you produce surface antibody and core antibody. But what can happen is that the surface antigen persists beyond 6 months, and this is a chronic infection. And if there's ongoing viral replication, this can cause liver inflammation, which can lead to fibrosis. So who do we test? Well, anyone who is from a country with high rates of hepatitis B, which is a lot of Southeast Asia, South and Central Asia as well, Pacific Islands, Middle East, and some African countries, Aboriginal and Torres Strait Islanders, people in custodial settings, people with family members that have a history of liver disease, anyone who's ever injected drugs and continue to check every 6 months if there's ongoing injecting drug use, people with family or sexual contacts with hepatitis B, people who've had a medical procedure or blood transfusion overseas or a traditional practice or ritual where blood's involved. Patients on dialysis are checked annually, and it may be a part of investigation of abnormal liver tests, part of a liver screen. So when someone is diagnosed with chronic hepatitis B, what should be done? So they should have blood tests every 6 months, checking their surface antigen and antibody annually, e-antigen annually if positive, and then if it becomes negative, you don't have to check, and a DNA annually, although you can do that 4 times a year if they're on antiviral treatment. You can check for Hep D or Delta virus once or further times if you have a reason to. Antiviral treatment may be considered, and we'll go through some of the criteria for that. So the 2 main agents we're using at the moment are entecavir and tenofovir. All patients should be worked up to determine where they're at in terms of fibrosis or cirrhosis, because that has implications for their management. And surveillance for HCC is every 6 months, and when to commence depends on their age, ethnicity, and family history. So anyone who has a family history of HCC or is cirrhotic should be commenced at the time of diagnosing their Hep B. Anyone who is of African background, they get commenced on HCC surveillance from the age of 20. For Asian men, it's from the age of 40, and Asian women from the age of 50. And this is just based on the prevalence of HCC in these different groups. Entecavir 0.5 milligrams daily is the mainstay of antiviral treatment. And there's also tenofovir, which is safe in pregnancy. And we'll get to when to treat with antivirals on this slide. So anyone with cirrhosis and a detectable DNA should be treated. In terms of what to do if they have decompensated liver disease or Child-Pugh B or C, that should really be discussed with a hepatologist who can decide whether or not they should be referred for transplant. If they're not cirrhotic and they have an elevated ALT or a liver biopsy showing chronic liver injury, then they are candidates for antiviral therapy. So if their e-antigen is positive and their DNA is greater than 20,000, or if their e-antigen is negative and the DNA is greater than 2,000, they're candidates for antiviral treatment. Although not a PBS reimbursable criteria, those with a family history of HCC should also be strongly considered for treatment. And the main reason is if you can get their viral replication under control and get the Hep B under control, then their chance of Hep C is reduced dramatically. So when you're commencing patients on antivirals, it's important that they understand why they're taking it, that they need to take it every day, and it's most likely going to be lifelong. So there are stop criteria. For example, if someone loses their surface antigen and that's demonstrated to be sustained over 12 months, then they could be candidates to come off antivirals with very close monitoring. But for most patients, it's going to be lifelong. So you need to make patients aware of that. Otherwise, they run the risk of a bad flare, which can make them very sick. And I remember during COVID, a very intelligent man in his 40s who was transferred to RPA. He'd stopped taking his antivirals because he'd run out and just hadn't got another script. And he had a very bad flare of hepatitis. His liver decompensated. He got very sick and actually needed a transplant. Just make sure that patients know this and that you're fairly sure that they'll adhere. If caught early, a flare can be controlled by recommencing the antiviral, but in some cases, if it's a bit too far gone, unfortunately, they may need to be transplanted. And for anyone looking to expand their skill set, you can do the S100 antiviral prescriber training. So in terms of prophylaxis, so a lot of oncologists and rheumatologists, hematologists are diagnosing Hep B when they do screening prior to commencing treatment. So for people that are surface antibody positive and commencing immunosuppression, then they should be commenced on antivirals. But if their surface antigen is negative and their core antibody is positive, suggesting they have been exposed to the virus in the past, there are certain instances where they should be put on prophylactic entecavir. So stem cell transplant, any B cell depleting or anti-CD20 agents like rituximab, and any treatment for acute leukemia or high-grade lymphoma should all be commenced on antivirals, and that needs to be continued for 2 years beyond the stop date of their treatment to prevent reactivation of Hep B because of the way that the DNA template lives in the hepatocytes forever. For lower risk chemotherapy, they don't need antivirals, but you would be keeping a close eye on their liver tests and checking surface antigen if the ALT was going up. And this diagram applies to pretty much all types of chronic liver disease with a couple of caveats. So got a healthy liver on the left. Hep B is not a steatotic or a fatty liver disease, but it does cause inflammation. And then the way that the liver responds to that is by laying down fibrosis, which if it progresses can lead to cirrhosis, which can then lead to decompensated liver disease, including a hepatocellular carcinoma. Now, the scary thing that can happen in Hep B is that you can go from an inflamed liver straight to a HCC, which is why we're so particular with the screening. We've also seen in fatty liver recently that patients can develop HCC also in the absence of cirrhosis, which is a bit scary. The other instance where that can happen is in genotype 1A of Hep C, which is a steatotic liver disease. All right, so how do you assess where they are on that continuum of normal to fibrosis or cirrhosis? Well, we actually have some good non-invasive tests these days that are based on a blood test and the patient's age in the case of FIB4. So you can look these up online or on any of your medical calculators. FIB4 is based on age, AST, ALT, and platelets, and APRI. I can't remember the exact parameters, but you can pull it up online. And if they're normal, then that suggests there's a very low likelihood of that patient having any significant fibrosis. If those tests are elevated or inconclusive, then the patient can proceed to an ultrasound-based test, of which there is FibroScan or shear wave elastography, which can help to confirm. Now, we're doing very few liver biopsies for staging of fibrosis or cirrhosis these days, but if the diagnosis is unclear or the tests are all discrepant, then they may need a liver biopsy just to clear up where they are on that pathway, because that will determine their treatment and surveillance. So how do we screen for hepatocellular carcinoma? So it needs to be done every 6 months, and that's because the doubling time of a HCC is 6 months. And if they're picked up when they're small, they're usually much more readily treatable with loco-regional therapies like a microwave ablation or a TACE. So an ultrasound every 6 months is good in most cases. Some guidelines recommend an alpha fetoprotein blood test, and that is most people's practice to do both of those in conjunction. You can get some HCCs that don't produce AFP, so don't be reassured by a normal one, but it can obviously increase your suspicion if the ultrasound's reported as normal, but the AFP is quite high. Now, not all centres will describe the visualization score, but essentially that's graded from A to D. A means they've had a really good look, B means they've had a fair look. C means they're not fully confident that they've seen all of the liver tissue and can exclude a HCC, and D is even worse than that. So if the visualization score is C or worse, then that patient needs a multi-phase CT or MRI at their next surveillance interval, or sooner if you have a high clinical suspicion that there's a HCC that was missed on the ultrasound. All right, so we have another question now. Which of the following patients would you consider commencing on antivirals? And there's just one answer. Okay, fabulous. So 77% got that one correct. So look, in the absence of any further clinical information, you're looking for the one who's surface antigen positive because they're the one with chronic Hep B. So they're the one who you consider for treatment. And you'd also obviously work them up for fibrosis to determine whether they have fibrosis or cirrhosis, and work out whether they need to commence HCC surveillance. If they're cirrhotic, you would consider referring them to gastroenterology for all of the other usual cirrhosis care. So assessing them for encephalopathy, for fluid overload, assessing their nutrition and determining whether they need to see a dietitian, and all of the other things like bone health, etc. All right, so before we move on to Hep C, does anyone have any questions that they would like to ask about Hep B? Otherwise, we can do some at the end.
I was just going to ask Emily.
Yep.
Oh, you can hear me? Good, good.
Yep.
How, you're talking about the vaccination of newborns after delivery to a mother of Hep B surface antigen positive. So I'm just wondering, how effective is that? What sort of proportion of kids are prevented from getting Hep B by that strategy? Do you got any idea?
Oh, so just in general, in terms of the vaccination program?
Yeah.
I think it's
in the
exceedingly
order of
effective. Yeah,
right.
I don't know the exact number, but I would assume it's close to 100%. Yeah.
Oh, okay, good. That's interesting. Yeah, good.
This is just for all comers. Yeah.
Yeah. And then Kevin's put something in the chat that people who tend to become Hep B vaccine non-responders, do people tend to be Hep B vaccine non-responders as they age?
I don't know that age is part of the criteria, but certainly people who have HIV or other immunosuppression might not mount an adequate response. And actually, people with HIV and on dialysis get a double dose course. They get a jab in each arm and they get a fourth dose. So I don't know if age, strictly speaking, is part of it. It's more immunosuppression.
Yeah, Kevin just notes that he had a few patients in their 60s and 70s that haven't mounted a Hep B surface antibody response despite boosters. Yeah, it happens sometimes, doesn't it? And even in younger people too.
Yeah. So yeah, I would, if that's happening, I didn't mention, but you would obviously just check that they haven't actually acquired Hep B in the interim. So just recheck all their serology before you revaccinate. But in most cases, you're heading for a second course.
Great, thank you.
All right, shall we move on to hepatitis C?
Yes, sounds good.
All right, so we'll start with a question. Tom is a 29-year-old man who injects drugs intravenously 3 times per week. He reports using clean fits and never sharing. He undergoes bloodborne virus testing, which shows hepatitis C antibody positive. Would you treat him for hepatitis C? So only if he stops injecting. Yes, with 8 weeks of Mavorette. Yes, with 12 weeks of Epclusa. Yes, if hepatitis C RNA is also positive. Well, most people that answered got it correct. So yes, you do need to confirm with an RNA test before treating, because the antibody will be positive forever after an exposure, but it doesn't tell you whether you've cleared the virus yourself or not, which can happen in about a third of cases. So ongoing injecting drug use is absolutely not a contraindication to antiviral treatment. And in fact, injecting drug users can reduce transmission of the virus. So as long as the patient is agreeable and likely to be adherent, then you should be prescribing antivirals if the RNA is positive. And in fact, the widespread testing for Hep C and unrestricted access to DAAs has resulted in a big decrease in Hep C transmission amongst people who inject drugs. And similar to Hep B, the reason that we treat Hep C is to prevent progression of liver disease, prevent the development of the complications of advanced liver disease, such as HCCs.
Can I just mention also, there's also the risk of materno-fetal transmission too.
Yes, absolutely. Yep. And we'll talk a bit about pregnancy, but we can't treat Hep C during pregnancy. So treating prior is good.
Yeah. And this is another question that people may be wondering about. If someone has Hep C antibody positive, are they protected against future Hep C infections?
No, there's multiple, there's 7 different genotypes. And I have heard of people having not double digits, but I've heard of between 5 and 10 courses of antivirals for repeat infections, not inadequate treatment, but new infections. Yeah.
Interesting.
That was in a prison setting that I heard that from. Which may also reflect the fact that in prisons they're actually very good at testing and treating Hep C, so probably picking up more Hep C than in the community in some cases. So Hep C is a bloodborne virus. More than 80% of cases in Australia are in injecting drug users. Sexual transmission is pretty rare and does require blood-to-blood contact, and so that's more common amongst men who have sex with men. Mother-to-baby transmission occurs in 5% of mothers who are Hep C RNA positive at the time of birth. It's felt that it's unlikely to, or very rare to cross the placenta, and that it occurs at the time of delivery. Caesarean section is not recommended as a method to try and reduce transmission. Some interventions during the birthing process can increase the risk of transmission, like fetal scalp electrodes and things, but if that stuff is needed for the safety of the mother or the baby, then that should be still done as per usual protocols. And Hep C can be treated in children, which we'll get on to. So it can also be transmitted via tattooing, blood transfusions, even a cutthroat shave at the barber if they're not using sterilizing in between shaves. So the primary infection is usually subclinical. Again, a mild hepatitis can occur, and the peak viremia usually occurs around weeks 2 or 3. About a third of people will clear the virus spontaneously, but in 2/3 of cases it will persist, and in 25% of those who have a chronic infection, they will go on to develop cirrhosis. 25% will get cirrhosis. So who do we test? Well, it's very similar to Hep B, and the countries of high prevalence are very similar to Hep B. I will make a special mention here to Egypt. So Egypt has gone from being one of the countries with the highest prevalence, 10% of their population was affected in 2014, to last year having one of the lowest prevalence, being one of the lowest prevalence countries, less than 0.4%. So over 6 million Egyptian people were infected with Hep B during their mass schistosomiasis vaccination program between 1950s and 1980s. Unfortunately, sterile injecting vaccination equipment was not used. But due to widespread testing and availability of free treatment, they have had a great success in that. So it shows that where there's resources and a commitment, that Hep C can be almost eradicated. So the testing is much easier to interpret than Hep B. So if the antibody is positive, they've been exposed to the virus at any time. You don't know if that's a current or previous infection. So if the Hep C antibody is ever positive, you never need to check it again. All you need to check is the RNA. So if the RNA is positive, then they have active viral replication. You can do quantitative or qualitative, but both suggest that there's active virus. And that's a current infection that should be treated with a few exceptions. So genotypes are 1A, 1B, and then 2 through 6. Previously, the PBS required you to check the genotype before the advent of pangenotypic DAAs. Now that we have pangenotypics, you don't have to check that as a requirement. But I would if you're retreating or if they're cirrhotic, because that can change the treatment. So the antibody, there's no limits on ordering that. The RNA, you can get a quantitative 2 times a year if they're on treatment, or a qualitative once a year if they're not on treatment, otherwise 4 times a year. So just remember, if they've ever had a positive Hep C antibody and you want to know their current status, just go straight for an RNA. So prior to treating, what you want to know, now the principles we learned in Hep B also apply here. So you need to know if there's cirrhosis. So you can do a priori Fib4 to hopefully rule out fibrosis, but if it's indeterminate or rules in, then you should proceed to an elastography-based test. You need to know if they've been treated before, if they have co-infection with Hep B or HIV, if they're pregnant, what their adherence is likely to be. Some drug interactions can come into play, so you can use that Liverpool Hep drug checker to go through their medications and make sure there's no interactions, and just your standard blood tests. So if there's co-infection with Hep B or HIV, you might want to refer them on to a gastroenterologist for management. And so in terms of cirrhosis, so there may be some clues to cirrhosis whereby a normal a priori Fib4 might not reassure you. So if you can see on their bloods that their bilirubin is up, or there are other markers of synthetic dysfunction like a low albumin or a high INR, or if there's thrombocytopenia suggesting portal hypertension, you might not be reassured by a normal a priori Fib4 and you might proceed to further testing. So just interpret those within the context of each patient. Okay, so treatment, look, it's pretty simple. You can take your pick from Mavorette, which is 3 tablets a day for 8 weeks, or Epclusa, which is 1 tablet a day for 12 weeks. So some patients may have a preference for less tablets or less time. Mavorette, you give 12 weeks if they have cirrhosis. Probably more the domain of gastroenterologists, but with Epclusa, if you're treating someone with compensated cirrhosis and genotype 3, you'd add ribavirin, or if they're decompensated, you'd also add ribavirin to the Epclusa. So unfortunately, in pregnancy, we are unable to give these DAAs due to concerns about teratogenicity. Similarly, in breastfeeding, there is concern for side effects in the breastfed infant. So we would defer treatment in those cases. In terms of patients with cirrhosis, so if they're compensated and the MELD is less than 15, then they should be treated. And if Hep C is the cause, the primary cause of their liver disease, then it will get better. If the MELD is greater than 15, they should be referred for transplant and treated on a case-by-case basis. If the MELD is over 20, they're probably unlikely to recompensate with treatment, but they may. So if they're not a candidate for a liver transplant, then you may give them a go and just see if they can get some improvement in their liver function. And if they're reinfected, we retreat with some salvage, with different regimens. So the main goal of treatment is to achieve sustained virological response, which means when you check their RNA 12 weeks post the completion of treatment, it is negative, and that in the vast majority of cases will confer an ongoing cure from hepatitis C. And these drugs are very effective compared to the previous interferon days where they were only about 10% effective and patients got horrible side effects. These treatments are so easy and they've just been a real game changer. So I'll just go on to post-treatment. So you can do a Hep C RNA at the end of treatment, and if it's positive, you can proceed immediately to a salvage regimen. Most people would just wait till the 12 weeks, and then if it remains positive, give them a salvage regimen. There is a pan-genotypic salvage regimen, which is Vosivi, but there are some other ones if there's any other sort of complexity. And if they're Hep C, if their SVR is good, they don't have cirrhosis, their liver tests are normal, they're essentially cured and you don't need to see them again. But if they're cirrhotic, they need ongoing surveillance of Hep C and management of their cirrhosis. And if their liver tests remain abnormal, then they should have further testing and treatment. Testing for other causes of liver disease to determine why, if the Hep C is gone and their liver tests are still abnormal. So another question. Sarah is a 32-year-old chef. She's on Suboxone for prior opioid dependence. She takes no other regular medicines. She last injected drugs 2 months ago. Hepatitis C testing shows her Hep C RNA is positive, HIV and Hep B are negative, and her APRI is less than 0.5. What would you recommend to treat her Hep C? Yeah, okay. So Mavorite or Epclusa would both be options for her. We haven't checked if she's pregnant and we haven't checked her renal function, which would obviously be important to do. In terms of option 1, so repeating the RNA in 6 months. So if people are actively injecting drugs, then there's a risk of transmission. And in that case, I would just get on and treat them. If they're not engaging in any high-risk practices, then if their liver tests are normal and they're well, then you could repeat in 6 months in the hope that they're in the 1/3 of people that can clear it. But it's equally valid to just treat.
Can I ask a question?
Yes.
Why would you choose one over the other, Mavorite or Epclusa?
So look, I'd probably pick Mavorite, so it's done and dusted in 8 weeks. If it was me, some people don't like taking tablets, so they'd prefer to just have 1 tablet a day for 12 weeks rather than 3 tablets a day for 8 weeks. Renal function wise, Epclusa, you need to dose reduce for GFR 30 to 50 and not give if GFR is less than 30, I think. And some drug interactions may be important, with one or the other.
And Nada's in the chat also made a comment about contraception.
Yes, excellent point. Yep, very good point. Yep.
So to basically counsel and make sure that they've got effective contraception.
Yep, make sure not pregnant and then,
Mm-hmm.
Yeah, very good point. Any questions about Hep C before we move on to our last section, which is quite brief?
What is it? Mavorite can inactivate estrogens. Nada's made a comment.
Oh, okay. In terms of choice of contraception?
That's an interesting point. It might make it less effective. An estrogen-based contraception.
Mm-hmm.
Yeah, so maybe a long-acting, a progesterone-based contraception.
All right. Well, I might just run through the final section, which is on alcohol-associated liver disease. Now, I think this is the final question that I'll torture you with. Which is the most effective treatment for acute alcohol-associated hepatitis? Alcohol abstinence is, for the most part, the mainstay of treatment for the management of acute alcohol-associated hepatitis. Steroids are used in severe cases, and they're in cases where they do work, they can improve mortality, but they don't always work. Pentoxifylline has been demonstrated to not work, and so we no longer use that. Liver transplantation is a treatment option, which is a new-ish treatment, and that's for severe cases of acute ALK-HEP that are non-responsive to corticosteroids, and patients have to be highly selected based on strict psychosocial criteria, and there is in that cohort evidence for improvement in mortality. So this is alcohol-related liver disease summarized in one slide. So it is a spectrum of disease. So the first thing that usually happens in heavy drinkers is that they get a big fatty liver, steatotic liver, which can then lead to inflammation or hepatitis and fibrosis. With ongoing drinking or other liver insults, they can develop cirrhosis, which can then lead to complications such as hepatocellular carcinoma. So although not all of these arrows indicate, but it is true that at virtually any stage, almost every stage, with abstinence from alcohol, you can revert to the previous stage. And certainly if you have decompensated liver disease with abstinence over sometimes a 12 to 18 month period, you need to be patient. The liver can recompensate, and you can improve your mortality. Similarly with the other stages, with abstinence, if it's able to be sustained, the liver can regenerate and repair itself. And I do tell that to patients with alcohol-related liver disease. It's one of the good things about alcohol-related liver disease. If you can take away the alcohol, the liver can repair itself. So down the bottom here is alcohol-associated hepatitis. This is a slightly different entity. Patients are typically cirrhotic. We see more than 40% actually when you biopsy them are actually cirrhotic. Maybe the mild ones aren't. But this condition has very high short-term mortality. They can get very sick. They can present jaundice with infections, with decompensated liver function. And our treatments are quite limited in terms of what we have to offer them, with abstinence being the mainstay. So I won't dwell on this too much. Suffice to say that ethanol poisons the body in a number of ways, predominantly due to the production of acetaldehyde, which leads to production of reactive oxygen species, leads to accumulation of lipids, inflammation, fibrosis, and puts them on a pathway to carcinogenesis. So acetaldehyde is carcinogenic in and of itself, and that's just a few of the mechanisms by which you develop each of the liver diseases. And so you typically do need fibrosis. We typically do see patients with fibrosis and cirrhosis where carcinogenesis occurs, so cirrhosis in order to develop HCC. So just focusing on alcohol-associated hepatitis, because it is a slightly different entity. So it is life-threatening. You can assess the severity using some non-invasive scores such as MELD, Maddrey discriminant function. The Glasgow ALK-HEP scale isn't really used much outside of Glasgow. Mild cases are most common. They do have a lower short-term mortality, and the condition is reversible with abstinence. The studies have shown that they actually have pretty poor long-term outcomes, although that probably relates to deterioration of their underlying cirrhosis. Severe cases are associated with a high short-term mortality. So in those that respond to corticosteroids, which is if they respond between days 4 and 7, that's continued for a month, their survival is in the order of 85% at the 6-month mark. However, if you're a steroid non-responder, your survival's much worse at 25% survival at the 6-month mark. Again, I won't dwell on this too much, but the definition of ALK-HEP is the onset of jaundice within 8 weeks of heavy alcohol consumption. Often patients have been feeling really unwell and so stopped drinking because they felt so sick. And then sometimes even weeks later, they've developed jaundice. So sometimes it's hard for them to conceptualize that this condition is from alcohol because they've already stopped drinking when they see the jaundice. You typically require greater than 50 grams of ethanol a day for at least 6 months, although often it's for many, many years. Less than 60 days of abstinence between before the onset of jaundice, bilirubin over 50, and AST over 50, and AST ALT ratio of greater than 1.5, And the transaminases are typically less than 400. And if they're higher than that, you need to think about a secondary or a different cause. And you rule out all your other causes of acute hepatitis with a liver screen. So long-term abstinence is the best predictor of long-term survival after an episode of ALK-HEP. However, more than 50% will resume drinking. So it's important to try and use presentations with ALK-HEP as an opportunity to engage them in addiction treatment. Prednisolone, nutrition, liver transplant for severe cases, and there are some clinical trials at the moment that I'm hopeful will result in a greater treatment option in years to come. So that's the end. I'm just going to give you my take-home points. So remember...
By the way, just very good, Emily. You've got 5 minutes.
Oh, okay. Excellent. Take-home point. So remembering to do bloodborne virus screening on patients that are at high risk so that we can identify viral hepatitis, identify and refer or treat, if you're an S100 prescriber, patients with chronic Hep B to improve their outcome. Be confident to treat Hep C yourself. You can do it. Alcohol-associated liver disease is almost always reversible with abstinence. Assess for fibrosis. You know how to do that now. It's pretty easy, just with some blood tests and online calculators. And remember HC screening every 6 months. So sometimes, look, if you're working in a public drug health service, you will probably have patients like I do that aren't quite making it to liver clinics or, don't have a GP, and you may be harm minimizing by doing their HC screening and some other things for them. So now you know how to do that as well.
Excellent. Thank you very much. That's very good.
Worries. Questions?
Any final thoughts or questions from the audience? I think we've gone through most of them. That's really, really very valuable. Thank you very much, Emily, for that presentation. I'll just give the audience another minute. Actually, can you just go back to your last slide for a second?
Oh, yes.
There was something I was going to ask you. So if someone stops drinking alcohol and they've had sort of alcoholic hepatitis, and then they stop, can they still get some scarring of the liver, some fibrosis, or?
So if it's pure ALK-HEP and they don't have cirrhosis, they can have portal hypertension and be very sick, ascites and varices, but that all can resolve with abstinence, and they won't necessarily have any long-term liver damage. But most patients that we see, and we do sometimes biopsy to confirm the diagnosis, which will often show there's also cirrhosis. So the cirrhosis will never fully go away, but they can recompensate with abstinence, and their MELD and child PU can drop right down. They can sort of, that process can take up to 2 years sometimes. So you do need to be patient and
So there is some hope then.
We have a hand up from Wendy, if you want to unmute yourself to ask your question.
Yeah, thanks for that, Emily. Just to mention, we had someone with child PUC last year on opioid treatment who was also a drinker and had all the peripheral stigmata and ceased drinking because we had end-of-life discussions with her rather than alcohol cessation discussions. She's child PU A, she's on buprenorphine, doing really well. And I think it's really important how we have those discussions with people as well, because I actually didn't expect this person to still be around at Christmas last year, let alone this year. And she's looking amazing.
Fabulous, yes.
Yep.
Yes, a patient comes to mind who was told several years ago that they didn't have long to live, and so they drew out all their super and did lots of things with their finances, but years later they're still here.
Yeah. So I guess my point is how we have those discussions as well with our clients as enhancing rather than punitive.
Yep. And like I mentioned, I sort of tell patients that it's actually good that they have liver disease that's from alcohol, because it's one of the ones where the liver can regenerate and repair itself, and that there's always hope that their liver function can recover. And tell them about when we transplant livers, you can chop half a liver and put it into someone and it will regrow. And yeah, just to explain that it is possible.